Good morning, everybody. I'm Marisu Gallardo-Rios, one of the Pediatric Fellows from Cornwall. So today we're going to talk about Pediatric Palliative Care Approach in Pediatric Oncology. So the main objectives from this is that I'm going to describe the evolution of pediatric palliative care in pediatric oncology, describe some basic principles in pediatric palliative care in oncology and the needs of this population, and also describe palliative case referral practices and the outcomes in the pediatric population. So oral cancer rates in children and adolescents have been steadily increasing since the 1970s, with leukemia and brain tumors being the most frequently diagnosed. This increase is paralleled by the marked increase in also survival rates at 5 years, from 58 in the 1970s up to like more than 80% nowadays. So with these advances in therapeutic approaches, these have led to dramatic changes in the cancer trajectory, not only improvement in survivorship, as I mentioned, but also in transition of cancer from an acute disease to a more chronic condition. Despite all available data, literature of numerous advantages of pediatric palliative care implementation in the management of pediatric patients, pediatric palliative care is still poorly implemented in oncology. About 56% of children with cancer do not have access to pediatric palliative care before death. 44.2% of children with advanced cancer are referred only at the end of life. And only 5% of pediatric oncologists and the child's family discuss advanced care planning. What are some of the barriers that we're seeing? First, the uncertainty of the prognosis. Also, there are some misperceptions about palliative care from providers and from families. From providers, for example, the lack of perceived benefit from palliative care by some primary oncologists. The concern that it will be an overlapping of roles from palliative care and the oncology team. The fear of harming the relationship between the physician and the patient. And also a concern that the early introduction of palliative care services could increase parental burden. The misperceptions from families are this fear of giving up, and also the misconception that palliative care is consistent with a curative intent. Another barriers are that palliative care is only associated with end-of-life care. The late referrals that we have, where the disease sometimes it's way too advanced for palliative care to make an impact. And in some countries, the poor access to essential analgesic drugs, also lack of services and providers dedicated to pediatric palliative care, and limited development of care models. And I think it's because of all these barriers that it's not surprising that pediatric palliative care integration in pediatric oncology remains still a little bit suboptimal. Just like the evolution of pediatric palliative care in pediatric oncology. So around 1997, the Association for Children Palliative Care and the Royal College of Pediatrics and the Child Health together categorized chronic and life-limited conditions. All of these conditions were appropriate for palliative care, but the nature and the level of palliative care involvement varied significantly from one category to another. The childhood cancer, for example, was categorized in the ACT number 1. That means that there is a curative treatment that may be feasible, but can fail. Palliative care may be necessary during phases of prognostic uncertainty and when treatment fails. So that was the late 90s. Around 2012, the American Society of Clinical Oncology had a provisional opinion of supporting the integration of palliative care for patients with advanced cancer and brain symptom burden, all patients, adults and kids overall. It was in 2013 that the first guidelines on integrated palliative care in pediatric oncology were published. These guidelines kind of like recommended that creating a specialist interdisciplinary team that can provide collaborative multimodal care across all settings. The purpose of this was to provide support to children and their families while ensuring the quality of life of the child. In 2015, palliative care was proposed to be as a standard of care in pediatric oncology after a study where it was a review of literature and synthesis of more than 73 articles, where it was addressing the social needs of children and adolescents that live with cancer and their families. So after this review of literature, this standard of care was proposed by waivers. Now, at the end in 2020, the American Society of Clinical Oncology, in one of the publications, recommended integration of palliative care in the routine care, not just for advanced cancer or high symptom burden, in the routine care for children, adolescents, and young adults with cancer. But yeah, some basic principles about pediatric palliative care in pediatric oncology. So a general approach and supportive care are mandatory for all cancer children. A specialized pediatric palliative care should be provided well before the end of life period. Being a child with an incurable or potentially incurable oncological disease, considering the prognosis, the physiological changes related to growth, and the complexity of care. Earlier introduction of pediatric palliative care supporting patients with cancer has improved quality of life and symptom burden overall. And early introduction has also helped in the development of a trusted relationship between healthcare providers and families. So now starting with this, let's just talk about the needs in pediatric oncology. We're going to focus on the child needs, physical symptoms, psychological concerns, social concerns, family needs, communication needs, ethical needs, and team needs. At the end of life care and advanced care planning. So child needs, the clinical needs of children with cancer may vary based on the type of disease that they have, the treatment-related possible complications, the previous or acquired comorbidities, and changes along the trajectory of their own illness. The most frequent physical symptom in children with advanced cancer are chronic pain and fatigue, followed by some respiratory problems, nausea, vomiting, some constipation. But overall, pain is going to be the most common symptom experienced in children with cancer in any stage. And it's going to be more often seen in children with solid tumor rather than children with hematological. Multimodal pharmacological and non-pharmacological approach tailored to the child's age and development is going to be fundamental in managing their symptoms and chronic pain. There are different drugs that we can use for chronic pain. We already know, but they're categorized in 4 categories: non-opioids, opioids, adjuvants, and local anesthetics. And in the non-drug therapies, we're going to focus as for physical, behavioral, and cognitive dimensions, depending on whether they primarily work by influencing the children's sensory system, their behaviors, or their thoughts. So some of the techniques that they use are distraction, attention, relaxation, or behavioral management. And psychological concern, this is also widespread in children with cancer. And the most common symptoms here are anxiety, sadness, depression, fear, and boredom. And spiritual crises are also seen, especially among older children. But on the other hand, hope and faith often represent a protective factor for these kids, and it helps them feel resilience and uphold the dignity of their lives. Some of the social concerns that are also frequent in children with cancer, also in the older ones especially, are social isolation due to frequent hospitalizations, and the shame of social image and poor social understanding of their illness. Adolescents with cancer feel that the illness destroyed the hope of a promising future. Got my screen, Laura. Do you still see my screen?
Melissa, I'm not sure if you can hear or not, but we've lost your feed.
Oh, there we go.
Do you hear me now? I don't know what happened.
Yeah,
Sorry.
okay. Yep. No, we're back up. Thank you.
Okay. My computer just froze, so I'm trying to. Okay. Here we are. Okay. Sorry about that. I don't know what happened. Can you see my screen now?
Yes, we can see your screen.
Okay. Thank you. So, adolescents with cancer felt that the illness destroyed the hope of a promising future for them. And also, prolonged hospitalization meant the disruption of the school play. And it became a transformation of the school play to a home or hospital cycle. And children found this very distressing. So overall, physical needs represent the main contributor for global suffering in kids, but they are often influenced by psychosocial distress and vice versa. So this is just a table that summarizes all the most common used medications for pain and other common physical symptoms for these kids with typical pediatric dosing information. The main difference with adults is like we go weight-based and sometimes just age-dependent. So I just placed it here for references.
Marisu, your slides are not advancing. We're on the title slide right now.
Oh, that's weird. It says your screen sharing is out. Let me stop share and then I'll try it again.
Sure, yeah, that might work. Stop sharing and share it again.
Sorry about that. It advanced for me, but I don't think it advanced for you. Can you see now?
We're good to go. You're back on the drug screen there. Thank you.
Okay. So this was the table that I was referring. So we can go now to family needs. So pediatric cancer is also going to be a family illness. Physical, psychological, and spiritual concerns are going to extend from the child to the whole family. And the needs of family members may vary according to the specific role in the care of the child, type of relationship that they have with the child, the age of the family member, the cognitive status or understanding level of the child's disease, and overall the cultural and spiritual beliefs. Some parents of children with cancer find it challenging to manage emotional issues like feeling of isolation and behavioral changes on their kids. Families also led very stressful life, navigating from hospital environment to dealing with uncertainties of the future, while also ensuring timely treatment for the children. And also families need some financial help, practical tips on managing the child at home, and supporting that all the children. So overall, like reinforcing good parenting, reestablishing behavioral rules and family routines, providing home care wherever possible, supporting hope, meaning emphasizing positive thoughts, avoiding false hope, and redirecting hope beyond survival are major parts of the family care that we can provide to these families. We also need to investigate the family's actual level of understanding of the illness and prognosis, so we can adapt our communication accordingly. Communication needs, so trusting and empathic communication is crucial in both settings, in pediatric oncology and in palliative care, as it's going to help promote continuity of care and to address all needs. Some families in some studies show that did not receive clear and honest communication about the child's illness, and they emphasize the need to know about the child's prognosis and what to expect. Children with cancer were also often not informed about their own diagnosis by their healthcare providers, and the older children were able to comprehend, felt a need to know. So it's important to have a good communication among all participants, including the children, because it's going to help define treatment preference on goals of care, and it's going to promote the child's participation in decision making. So whenever possible, we need to encourage families to include children and adolescents in decision discussions in an age-appropriate way, so we can address fears, answer questions, and provide anticipatory guidance. Communication is not a one-time only event. We have to continue exploring this throughout their disease, exploring the doubts or fears for any other that they might be going through. So about ethical and team needs. So Ethical issues are of major importance in pediatric care. It is widely accepted that the child's best interest should be the goal of care. However, defining what's the best interest in the child is not always easy, especially in complex situations like kids that are dealing with cancer. The final decision overall is going to be a summary of multiple options on the basis of a specific clinical situation and looking with attention the child's and family's culture, values, and beliefs. The decision of withhold or withdraw therapy is another area of particular concern here. And some ethical reasons like futility of treatment, harming treatment, or poor quality of life are going to be some reasons for limiting or withholding treatment. Also, a unique definitions of these specific words are not fully identified. So a decision making should be always evaluated case by case. In regards to the team needs, most current education curricula, both in undergraduate and graduate levels, lack time dedicated to pediatric palliative care, making it difficult to disseminate and improve palliative care in this setting of pediatric oncology. Also, we need to remember that an effective pediatric palliative care relies on interprofessional collaboration to achieve shared goals. So pediatric palliative care education should also provide opportunities for interprofessional education and clinical training. So now let's talk about end of life. So end of life is going to frequently represent the moment of maximum suffering for the child and the family, with a rapid and unpredictable and challenging evolution. In this end of life period, the main goal is to relieve from suffering. It is going to be essential to frequently communicate with the child and the family, to assess the burden of suffering, and then coordinate with the multidisciplinary team that is involved in the child's care in any different setting, either at home, with hospice, in the hospital. Some of the most common symptoms by pediatric patients at the end of life are going to be pain, fatigue, dyspnea, poor appetite, weakness, anxiety, and sadness. But the ones more frequently experienced in children with cancer are going to be bleeding and symptomatic anemia. The conservative transfusion or not transfusion should be evaluated based on their symptoms and not just by a lab number. And we need to make sure that symptom assessment and problem management is guaranteed continuously for this family. Advanced care planning is going to allow patients and clinicians to come together to make decisions using a collaborative communication and considering scientific evidence and the patient's family's values, goals, and preferences. Advanced care planning needs to be initiated well before end of life. It also has a role in defining end of life care by defining appropriate level of intervention, treatment discontinuation, symptom treatment, and resuscitation. There was a study that evaluated some families in regard of some choices that they did, and in retrospective, some families regret providing acute hospital-based care for the child during the terminal phase of their illness, and also regretted their child receiving cancer-directed therapy at the end of their lives. So it is important to talk about these things in advance. And we also do an after-death care. Death does not represent the end of the care that we provide. It is essential to treat the body with respect and according to parents' wishes, culture, and religious practices. Grief after death have physical, psychological, social, and cultural dimension, and is going to be perceived differently by all the family members. And it can be more intense and prolonged, given the fact that it's a death of a child. The family should be allowed to have a meeting with the pediatric palliative care team, even with a psychologist if they need to, several weeks after the death of the child, to share their thoughts on the child's disease evolution, end of life care, and the family's overall doubts or any regrets that they might have. So we need to be there available for them. These are just, this is like a table that summarizes some of like pediatric palliative care intervention in different aspects. So we have symptom management, we have management of psychological, social, and spiritual needs, assessment of the quality of life. We have communication, family support, and coordination activities. And these are divided based on the different stages of the disease, either diagnosis, during diagnosis, at the end of life, and even after treatment. I'm not going to go in detail of all this table. I just place it here so you can see like all the different stages that we can treat and different factors that we can treat for your review. So now let's talk about the referral practices of pediatric palliative care in pediatric oncology. So worldwide, children with cancer were infrequently referred to palliative care, and they were referred late in their illness trajectory. The median time gap from cancer diagnosis to a palliative care referral was 18 months. About only 16% of them were referred to the initial diagnosis, and most of the referrals, like about 60%, happened after a cancer relapse. Children with hematological malignancies were referred to us less frequent than kids with solid tumor, and this is a similar data when comparing to adult cancer. Presence of symptoms such as presence of symptoms in general, psychosocial needs and poor prognosis are some of the triggers or commonly triggers to activate a palliative care referral. In the other hand, not addressing uncertainties or avoiding conversation about death and dying make it the referral either difficult or slow. So, for example, this is a study from 2021 where they wanted to evaluate initiating palliative care referrals in pediatric oncology, knowing that early palliative care has been shown to improve the quality of life with children, but realizing that referral practices by pediatric oncologists were inconsistent and few patients were actually having formal palliative care counseling. So knowing that, this team decided to do this study where they analyzed the patient characteristics used by the oncologists for a palliative care referral. And they used some audio tape interviews, and they used also some case scenarios that included these characteristics and see if they will actually activate it. So about 77, they have about 77 participants in 2 major academic institutions, including attending fellows, nurses, MPs, and child life specialists. 75%, more than 75% of these participants reported that palliative care was actually consulted too late. And surprisingly, 98% of these participants expressed the need for improving palliative care integration into care of their patients. They actually acknowledged 3 main things that have been improved to improving this palliative care integration, and it was improving communication, providing education, and overcoming system delays. So improving communication was mainly because they identified 3 main weaknesses within their practices. First, the lack of or a discomfort with difficult conversations surrounding poor prognosis or end of life between the provider and the patients and the patient family. 2 was the ability to deliver more direct prognostic information to the patients and their families. And then the consistency and clear interdisciplinary team communication. Now, based on these weaknesses, they mentioned that improving communication will be something that will help improve this integration. Providing education, yes, because they realized that there were some educational barriers to palliative care integration, such as lack of awareness about available palliative care team resources, and also knowing that some physicians were unclear of the potential benefits that palliative care consult could provide. They also mentioned that for the third one, for overcoming system barriers, some of the barriers that they were seeing is the lack of palliative care resources, inadequate ways for documenting important conversations about their preferences regarding end-of-life care, and also a lack of standardized tools for consulting palliative care. So about 85% of these participants mentioned that a screening tool will be helpful to standardize the referral practices to palliative care. And they mentioned that some triggers can help to do this referral. And they mentioned some of the triggers that you can see on this table were uncontrolled symptoms, poor prognosis, and some mental health needs, for example, were the most prominent. But as I said, they also provided them with some case scenarios with using these triggers that they have identified and see if they will activate a referral in these case scenarios. And as you can see here, even though they mentioned that uncontrolled symptom could be a trigger to activate a palliative care consult, in the case scenario that they were provided, only 49% were able to identify the uncontrolled symptoms to make a referral. So actually, this study uniquely demonstrates the comparison of pediatric oncology providers' theoretical palliative care referral practices with their practical referral practices. It also suggests that pediatric oncologists overall, they do want to improve integration of palliative care for their patients, and they need some standardized referral practices, recommending a screening tool to help them with this. And they also mentioned that providing better palliative care education or within the pediatric oncology group will be beneficial. So this is one of the tools that could be used. This pediatric palliative screening scale was found to be an effective screening tool to assess palliative care needs of children and their families. And their score will normally allow clinicians to initiate timely referrals. So pediatric oncologists may benefit from using dedicated tools like this one, so they can define the complexity of the needs. This scale helps identify children using 5 different domains. So the trajectory of the disease, expected outcome and burden for treatments, symptom burden, preference of care of the child and family, and estimated life expectancy. As you can see here, each domain, and this is part of the screenshot of part of the scale, and this is the other part. So as you can see, all the domains have different questions within that domain with multiple choices answered that will give you a score. If there were some doubts regarding like the questions, the answers for each question, actually on the side next, on the right side, it has some comment and recommendations of how to choose this answer. And based on the score at the end of it, if the score was between 10 to 14, they will consider introducing the concept of palliative care to the patients. And the score was 15 to 24, then they should do an approach to pediatric palliative care team. So they could help with symptom management while getting treatment for their cancer. And if it was more than 25% up to 22, then they mean that palliative care is going to be the focus of the care. This use of this tool has been associated with an early introduction of pediatric palliative care and overall a subsequent improvement of palliative life in this patient. There was a recent study from 2022. This study wanted to have some green lights on when to consider the request of a pediatric palliative care for children with cancer. So they developed these green lights. For example, at diagnosis, they recommended it was a life-threatening illness or advanced stage cancer. If diagnosis of the tumor with an event-free survival rate less than 40% with the current therapies available. During illness, they mentioned if it had progressive metastatic disease or recurrent or resistant disease. There were major toxicities during treatment. If they have had any prolonged hospitalization of more than 3 weeks or more than 1 week if it was in the ICU without any signs of improvement. And in any case of 3 or more unplanned hospitalization for any serious complication within a 6-month period. Related to complex needs, it was if they were having difficulty in symptom management, in particular with pain. If they noticed that the children and family were having major psychosocial stress or limited social support. Introduction of new devices like a trach or a G-tube requiring complex care, especially during transition from the hospital to their home. and if they were having some difficulties in decision making or communication process. So those are a few of the guidelines that this study recommended on where to activate the palliative care consult. Overall, the outcomes of the referrals have been shown to be like multiple from different studies. So overall, symptom assessment and symptom management is the main benefit they obtain. Being pain management, the benefit that was better appreciated by the children and their families compared to the management of any other symptom. It also facilitated emotional support for the children and their families beyond the child's death and into the bereavement phase. Children that had palliative care in their care were noticed to have fewer elective and emergency hospital admissions, shorter hospital stays, fewer intensive care admissions, and more home deaths. Palliative care also improved end-of-life care for the children and the families, and it facilitated less invasive diagnostic and therapeutic intervention at the end of life. And then it was also noticed that they were often less resuscitated. For example, there was a study, a retrospective chart review of like almost 150 children that went beyond bone marrow transplant, and they died following treatment. And the patients that had palliative care involvement, only 3% of them had CPR intervention, compared to 20% of patients who did not have palliative care involvement in their care. Another retrospective chart review, patients with solid tumors less than 21 years old, had two different cohorts, also one with palliative care and the other one without palliative care intervention. And the patients with the palliative care team had a significantly longer time between the first end-of-life discussion and their death. And the discussion were also noted to take place much earlier in the disease trajectory. Outcomes regardless of communication. So it facilitated, it overall improved the communication between the families and healthcare providers. It also facilitated the initiation of family meetings during the child's clinical deterioration. Pediatric oncologists have acknowledged the complexity of this shared decision making, and they appreciate the support they receive from the palliative care team. Also, the palliative care team will assist oncologists in prognostic discussions. From two different studies from parents and children perspective, one study called Decisional Regret among parents of children with cancer. Parents who receive detailed prognostic information report less decisional regrets than parents who receive less information. And for children, and this is a study called Hope and Prognosis Disclosure, these children who participate in discussion around their prognosis have reduced anxiety, reduced feelings of isolation, and increased adaptation to the illness. There are different studies, multiple evidence out there that show that adolescents and young adults prefer a modest disclosure regarding prognosis and end-of-life issues, and that disclosure leads to less suffering from them. Also, the support from our team help families have a realistic hope, and with that, they can engage in different activities and experience events that add some meaning to their lives. And lastly, we have help facilitated advanced care planning and documentation of an advanced directive. This has been shown in another study that improved congruence of the stated goals of end-of-life care, greater understanding of their wishes, and reduced anxiety as well. And other outcomes were identification and management of social concerns in children and adolescents with cancer that improve overall the treatment outcomes and their quality of life. Also, parents value the support they got in terms of managing finances and assistance to manage the child's needs at home. And overall, the referrals improve family satisfaction of care overall. In parents who receive bereavement services, these parents describe feeling cared for and supported by the staff. had a reduction in sense of isolation, and also improved coping and personal growth. This was another study that evaluated the impact of palliative care, and this was like from years ago. The impact of palliative care, sorry, in pediatric cancer patients, they evaluated 15 children that received, 11 of them received treatment, chemotherapy, and radiation. And once they incorporated pediatric palliative care, 3 new symptoms were identified for patients. 14 out of the 15 children had medication change recommendations. 11 out of 15 were referred for counseling. For 3 of these patients, they recommended patient care conference, and for 6 of these patients, they recommended family conferences. And this was a study over a 9-month period in National Cancer Institute. So, like, demonstrating that we do make an impact. So, there are different models trying to integrate pediatric palliative care into pediatric oncology. This is one of the most applicable and most effective model is the integrated care model. It is based on the synergistic integration of the palliative care team into the oncology team from the diagnosis. It implies an interdisciplinary approach where all the team members are going to be committed, are going to share the same care goal, and mutually collaborate and respect specific areas of expertise. So some of the considerations for this model are described here. Prognosis is difficult to define due to the lack of standardized criteria. The patient could experience a rapid and unpredictable evolution to the terminal stage. The patient may need frequent access to a hospital, even as death approaches. Referral to our team should be based on needs rather than life expectancy. The palliative care team can offer advice on symptom management without having to interfere with the treatment goals. Palliative care can be offered alongside oncological therapies, including clinical trials, and making sure that establishing a close and trusting relationship between the patient and the palliative care team is as important as establishing a good relationship from the patients and the oncology team. There was a recent study from 2022 that actually tried to summarize 5 different palliative care models using pediatric oncology here in the United States. So these are the 5 different models. All of them include a pediatric palliative care team that most of the time has a physician, nurse practitioner, and social worker. And the first model is the floating clinic. This is a floating clinic unit, meaning like this team is going to move along with the child in the hospital and consult them during their outpatient oncology visits, during the hospital admissions, during a daycare, chemotherapy, or during their transport. I feel this is kind of like the care that, at least in the hospitals that I know, like are using, even like in the system that we use, or we follow the patient wherever they go. The other model is that this is a specific embedded clinic. And this is basically the team is going to be situated in the disease-specific clinic, like a leukemia clinic or brain tumor clinic. And they are going to work closely with these patients and provide palliative care throughout their stage. And this is a clinic that, for example, is used at St. Jude's Hospital. The other model is a trigger-based clinic embedded in the oncology space. So this team is going to be available. They're going to create a disease-specific criteria for a palliative care referral. And when the child meets these criteria, the oncology team is going to refer, and then the palliative care team is going to see this patient in the oncology and just in the This is, for example, a model that is used in one of the San Diego hospitals. The fourth model is a consultation-based clinic in the oncology space. But for this model, they are not going to be self-referral criteria. And most of the time, the palliative care specialist is going to be a dual board certified clinician in palliative care and oncology. So the child is going to receive concurrent care in the same clinic and receive like joint advice. This. And the last one is telehealth clinic. Basically, it's going to provide access to children and families who live remotely or in rural areas, so they can have like some of these services. I think that most of the hospitals, I would say, like also have this option available for their patients. Overall, they believe that from these 5 models, a recent study believe that the embedded model facilitated a better acceptance of pediatric palliative care by the pediatric oncology providers, and also improve the education of their team, of their residents. So there was a study regarding this embedded pediatric palliative care oncology clinic that was called supportive care clinic. So in this study, they wanted to just basically show some characteristics after creating this clinic in their first 4 years of opening. They had around 248 patients in these 4 years with over 1,000 clinic visits. Their clinic visits grew nearly 300% from year 1 to year 4. From the deceased patients, about 78% of them had a DNR form, and 73% received hospice care. The time from the supportive care clinic consultation that occur, the time from the consultation to death increased from 74 up to 226 days over the 4-year period. And the proportion of like these consultations that occur greater than 90 days from the death increased from like 39% in year 1 to 85% in year 4.
And where was that center? Which center was that?
This center was
Was that the St. Jude's model?
This wasn't in Atlanta Center.
Okay.
Yeah, it was a center in Atlanta.
Thank
and
you.
they opened this model from 2017 to 2021. So those were this clinic was started in 2017 for them. So with this study, they wanted to just show that these embedded supportive care clinics or palliative care clinics can be successful, can achieve a steady growth with years, improving referral and the time of pediatric palliative care consultation, and with that, improving the end-of-life care for these children with cancer. Just and towards the end, these are some resources regarding the pediatric palliative care in pediatric oncology. LNEC is an end-of-life nursing education course. As well, the American Society of Pediatric Hematology Oncology also has some resources available. But I feel that one that we might use a little bit more is the palliative care conversation matter, because these sometimes provide some material to share with families, like the one that I'm showing here. That basically is because that will tell families what is palliative care, like how can we help the patient, and then like the physician can implement in each specific area what are the recommendations that we can provide. So just as a solution of this, a child with cancer needs care beyond their cancer treatment. We need to treat also their complex symptoms, the psychological support, and sharing existential and spiritual issues that they might be going through. The goal of the pediatric palliative care is to share strategies, tools, and skills with the pediatric oncologists so they can guarantee a continuous and multi-dimensional assessment and management of the needs that they have. Implementation of pediatric palliative care in pediatric oncology overall is going to improve the quality of life of the child and the family, going to reduce symptom burden, diminishes cost of care and access to ICU at the end of life, and makes dynamic. So we also have to focus on we are going to take care of the patient and the family as a whole unit. And these were my references, and I think that's it. Thank you.
Thank you for this, Mary. So you can probably go ahead and unshare the screen. A couple of things that I wanted to. First of all, it's always I don't know if it's affirming or amusing to me when we have studies that prove what we already find to be obvious. You know, in terms of the benefits and the outcome, we know that. That's why we do what we do, and I think it's sometimes like I say, it's affirming to get the studies that can validate that scientifically, but we sort of already knew that from the beginning. One of the things that I really was intrigued about early on, you had the timeline, and it looks to me like there are some pivot points at 2015 and at 2020. And just in terms of historical reflection, I'm going to ask the group for some input here. In 2002 or 2003, so we're talking about 20 plus years ago, I was at a small conference of pediatric palliative providers in Boston, in which we were trying to figure out how do we make a difference in the world, because there weren't that many of us, but we saw a significant need. And about that time, I had started a program at Vanderbilt Children's Hospital. And the team that we had that worked on that included the chief of Pediatric Oncology at the time. And the groups that we had the most difficult time accessing were pediatric oncology patients, even though we had the chair, the department, as part of this palliative team, and neonatology, but that's an entirely different story. And so, and I have just sort of seen that whenever I've dabbled in the pediatric world, that oncology seemed to have been a tough nut to crack. And so it's really kind of encouraging to see these moments in which the powers that be within the pediatric oncology community said, this is not only important, but essential part of pediatric oncology care. So the question that I have, since we have the benefit of having a number of both pediatricians and med-peds folks on here who've been around for a little while, how have you seen the landscape change in the last 10 years? So there was that one focal point on your timeline of 2015. The question I have is, is that making a difference? You had that last study, Marisu, that showed, that it does make a difference, that referrals are increased. Well, that's one program with just a few kids. And I'm just wondering if there's a sense from those that have been, dedicated into the pediatric world, are you seeing the tide change? That's my question to y'all. So, I'm looking at Brad, and I'm looking at Matt, and I'm looking at Mike, and I think there's a couple of pediatricians or Mike med-peds on there. So just kind of curious if you've seen the tide change in this last decade in terms of how this is being accepted in the hem-onc world.
I was going to give someone else a chance to talk first, but I guess I will. I think the tide has changed, but slowly, and there are still folks who don't get it, I guess, if I can be really blunt. So I think in my experience here, part of it's been a culture change of, having a program at the hospital, myself being an oncologist, and that's sort of helped, I think, culturally change the acceptance, and people realize like how palliative care can be helpful, not just at the very end and all of that. And I will say, I think most of the oncologists we work with at our institution now understand and accept us. Some are better than others. There's a handful that I know will invite us to the table right at the time of diagnosis. Those oncologists, I dare say, tend to be of the less experienced variety, i.e. younger ones. And I think, I hope that part of that is just training they've received about palliative care and knowledge about what this really means, as opposed to folks who've been doing this maybe longer that feel like, well, we've done this long enough without you. What do we need you now for? Which is not really appropriate either. So I think that overall there has been a shift. It's not universal. There are some docs that I know still won't really use us. And then when their patients in the hospital and things aren't going well, the other oncologists on service will reach out because we haven't been involved. So I think the tide, at least in my experience, has shifted, though there are always outliers who don't quite understand and will still, be standoffish about our involvement.
Yeah, and I just wanted to mention, he's not on the call, wouldn't be on the call, but I just, one name I really do want to shout out is Jim Fauner, who is a pediatric oncologist here in Grand Rapids. And Jim introduced me to the field of pediatric palliative care about 30 years ago. It was the mid 90s, and really has been a force here in Grand Rapids to make sure that this area is identified. So I don't know, Matt, you've got some experience. Do you see changes in the last decade?
What Brad is saying is right on. I mean, I agree that it's changed slow. But for me personally, what I've seen is that it can also, just like any department, I don't want to put it all on Pete Hemont, but if you have an administrator who is not really on board, it makes it very difficult for those under. So for instance, our director of the program, and Brad, I think you know who I'm talking about, she was a very nice person, but just, and I found out over time, it wasn't that she was opposed to palliative care. It was, I think she was afraid that somebody was going to screw it up. You know what I'm saying? It's like, this is my kid. He or she is in good control, and I don't want someone else kind of messing this show up. She's since left, went to General Peds, which is interesting. But I'm hoping that might then allow more integration with those, like you suggested, under. So I don't know. I just think that it's always going to be a tough nut, like you suggested with Hemont, because it's kind of especially that you do everything and we're going to get that end save result. So how do I balance that, knowing that you're in here talking about another option? You know what I'm saying? I was like, or do you ever not have somewhat of a turf war there? I don't know. I hope not.
Well, and I think Marisu did a nice job outlining the different models. It needs to be integrated. It's not a us or them versus.
Yeah, right.
Well, and I wonder, since the advent of the concept of concurrent care, right, where parents, prior to that, it's almost like you have to make a choice. Either, right, we're treating this disease with the goal of cure or remission, or we're flipping into hospice. So I'm curious, in the pediatric world, where does one bleed into the other? In other words, the concept of all these pediatric palliative interventions, is there a demarcation that we're then flipping to hospice care at end of life? Because again, a lot of pediatric patients will be getting hospice care as well as still there's a clinical trial, or, in the adult world, there becomes a lot of cost barriers to that. So I'm curious, since the advent of concurrent care, has that allowed the two to bleed together more seamlessly? What experience have folks seen there?
Yeah, I definitely think it has. And I talked about concurrent care a few months ago. In the oncology world, I think it's actually where concurrent care is the easiest to think about and pull off for exactly that reason.
Mm-hmm.
Yep, you can still do these different treatments beyond clinical trials, but hospice care can still be involved. It gets much more confusing in other areas where prognosis is even stranger to try to predict. So I think with concurrent care, it should make this easier and simpler to involve hospice, and then certainly even outside of that, palliative care well ahead of that. And I think it is just making sure oncologists, as Matt said, understand sort of the role of our team. It's not us against them, and that's been the culture shift we've had here. And for especially some of the, I think, newer oncologists realizing we're part of the team. As Marisu pointed out, and I should have mentioned, that was excellent, Marisu. Thank you for that overview. I, of course, am very biased about both these fields. But as she pointed out, there's roles beyond symptom management and things for the patient and support of the family. I think our support of the team is pretty massive. And even being in the room with the oncologist at the time of some of these hard conversations, sometimes I don't actually say anything, which I know is probably surprising to hear. But it's really that support of the oncologist, right, who needs that. And then they're asking me afterwards, do you think I did okay? And I'm supporting them in having a hard conversation. And I think that's a big role for our team as well. So that's part of that culture shift, realizing that, we are in the same team. I can help support you as an oncologist as you're fighting for, you know, whatever you can for this child.
Mhm.
So I definitely think the concurrent care part helps, because as frustrating as it is sometimes to tell families, oh, with concurrent care, nothing needs to change, which isn't exactly true in some situations. In oncology, it sort of is. You don't have to stop any of the things you're doing for the most part and have hospice involved. So it kind of makes it a no-brainer sometimes, but there's not really a downside to having hospice involved, because you can continue your regular treatments.
So I just wanted to just a peripheral comment I wanted to make, because one of the earlier slides indicated that one of the challenges with kids with cancer is social isolation. And this is just an advertisement, really. For those that are not familiar with the organization here in Grand Rapids called the Children's Healing Center. Currently it's on Fulton. They've recently obtained a new building out on the East Beltline, which they're modifying. And it's really designed, it was founded by a young woman who had survived cancer and had just remembered the challenges with social isolation because of her immunocompromised state during active treatment. And so developed this entire program called the Children's Healing Center, which is a place, you might have seen their billboards around town, good, clean, fun. And it's a really sophisticated HVAC system, sterilized environment where kids can come and play with each other. And it's just a really neat concept. They're now expanding that, so there's going to be a branch of that in Ann Arbor to serve the children in the Southeast Michigan as well. So if you know, I realize that many on here are adult focused, but you need to know about this place. It's a special place, and it's a gem of an organization. Brad, you may have a little more contact with them because of the nature of your work, but I just wanted to shout out to Children's Healing Center.
Yep, I agree. I think it's a great place, and it goes, you know, beyond even the oncology world, and they have great ways to connect families. You know, have a safe place for the child to have different experiences, but also connect families, which has been really meaningful as well.
Once again, thank you so much. It was a great talk, and appreciate that.